Okay.
So I'm looking here.
Mm-hmm.
But welcome everybody. It's 10:01, and for those of you that came on early, you might have seen me eating my chocolate egg. This is my COVID stress reducer. I have a vase in my office, and I take all the chocolate candy kisses, and then if you get it out of my office, you have to take the foil and roll it up, and I put it in a vase, and I'm collecting. It's called COVID and Chocolate. So that's what I'm doing to fight the COVID pandemic, is trying to keep myself in chocolate. Welcome everyone. My name is Dr. Connie White. I'm the Deputy Commissioner for the Kentucky Department for Public Health, and I am also serving the role as the Director of Nursing until we can get that role filled. We are repackaging that application right now, and we are hoping to, by the fall, have someone officially in that leadership role. I thank all the nurses for being so patient with me and helping me with this this role. There's a lot that goes on in the nursing world of public health, and I'm very passionate about that, and I wanted to be sure when we were between leaders that that work did not drop. We've been working very hard in the NEC on the CSG, the Clinical Service Guide. We'll have several updates. That will not be updated July 1. It will be August 1. I apologize for the delay, but as you all know, we all got a little sideways with our timelines because of the COVID pandemic. So the NEC is working very hard. The programs here at DPH is working very hard, and we will be recording a short video, as we did last year, from each of the programs explaining the changes with a PowerPoint. We'll have those on Train, so all the public health nurses can go to Train, they can watch those videos, and then your nurse supervisors know that you've been updated on any program changes in the CSG. A new change that I am hoping, and this is state government hope, that we will have ready by Friday, is a new change in the AR. That change will say that once you have had naloxone dispensed to your health department, if you have people in your syringe service program that have undergone naloxone training, they will be allowed to distribute that naloxone to clients in your syringe service program. So for some folks that have been very strapped, trying to do SSPs, and fortunately all of our health departments that have SSPs functioning have continued to function through COVID-19, and I can't thank you enough for that essential service you are providing. You will not have to pull a nurse to come to the SSP whenever you are giving out naloxone. If that staff has had training, they can distribute the naloxone. The other thing that we've heard from some health departments is that they have been getting identification from people before they distribute naloxone, and that's not necessary. You do need to report the number of doses that you are distributing, so we have that for records. But as far as someone's name and identification, that is not necessary. I don't know how many of you were on the Zoom call that happened between 9 and 10 o'clock. We had 176 people who attended that meeting. It was too short, but it was our first attempt of Linwood Sternecki, who has helped to pull an SSP council together, and the council decided we needed to talk about SSPs in the world of COVID. Dr. Stack was able to hop on between meetings and express his experience working with people with substance use disorder while he has done his emergency room work over the last couple of decades, and how critically important he knows this work is. So we have his complete support. We have the support of the NEC and the entire Department for Public Health, trying to give the support that we can as we are able to our syringe service programs. I wanted to congratulate Christian County just got their Board of Health to approve them moving forward for an SSP, so they still have the city and the county government to go, but at least they're moving in the right direction. We wanted to congratulate Bracken County. Bracken County just opened their SSP Monday, and we wanted to congratulate LaRue County that opened their SSP on Monday as well. So a lot of good work moving in the harm reduction world that's been complicated by the COVID pandemic, but but you folks on the ground that know and love your communities know how critically important it is, and I want to congratulate you for that. So let's go to our first speaker, Vivian Lasley-Bibbs. Vivian's getting a workout. She just did a presentation on the webinar on SSPs, but I asked Vivian, who's the branch manager of our Office of Health Equity in the Commissioner's Office, to talk to you a little bit about a new committee that we have just started last week, and wanted to let her share the information with you. Vivian, are you on, and can you share your slides with us?
So Dr. White asked me to share kind of a new initiative that we're doing here in the Department for Public Health, kind of a brainchild of hers, and I'm glad she kind of pulled the Office of Health Equity in, because many of you know already that our state has seen a disproportionate impact that COVID-19 has had on our communities of color here in Kentucky, and we really wanted to do something to show that we are really sensitive to that. We recognize that, and we want to do a better job in making sure that the unmet needs of this community the voices are being heard, needs are being met, resources are being delivered, services and access to care are in full effect for these communities. So COVID-19 has kind of revealed, taken the Band-Aid off of what we already knew. The pandemic was kind of that added layer on top. You know, when you have a scab that doesn't quite heal and you keep trying to, patch it and put things over it, and COVID didn't allow us to keep doing that. It kind of revealed some of the things that we said, okay, we've got to do better. And Dr. White likes the Maya Angelou quote, when you know better, you do better. So we're trying to do better. So to that end, we formed a health disparity data work group looking at data in our marginalized and vulnerable populations, also including our Black and brown communities in Kentucky. So why is COVID-19 a health equity issue? Well, it's because we've got many barriers to protection and to protect and make sure that the well-being among our low-income and marginalized communities are taken care of. Our children who live in poverty, our homeless population, people who are incarcerated, people who work in the gig economy, they go from job to job. Our communities of color, our immigrants and refugees, our elderly, our people who live with disabilities, and other marginalized and underserved communities. So what's the impact? Well, we've seen the morbidity, you hear the morbidity and mortality data that the governor has presented during this COVID pandemic. And we see across the state where we're having a disproportionate impact in our communities of color. So this work group was formed to look at the data and pull back the layers and see what we've captured and decide what questions we need to really ask. What deeper dive do we need to take? So we proposed 2 questions to this work group. And what can we learn from the data that we already have to change what we're currently doing? And how can we make outreach messaging and testing better for our communities of color? So there were things that we needed to consider. We needed to consider structural barriers, remembering that there's the social ecological model that really is the foundation for a health equity framework. Look at how that person interacts with other individuals, with their communities, with their organizations, and how that all can be impacted by public policy. And then we've got to consider the economic barriers that a lot of these communities of color are facing. So what have we already learned? Well, we know that communities of color and other marginalized communities are disproportionately impacted. We know that guidelines are needed to ensure equitable distribution of resources. We know that we really need to listen to our communities and address some of those cultural and social norms that related to social distancing and stay-at-home orders. Those don't mean the same things to different communities. And then we need to make sure that we are prepared, that we've built trust, and that we're transparent as we work to address the outbreak response for COVID-19. So what are challenges and barriers that we've already identified? Well, in communities of color, particularly in the African American community, there are myths regarding COVID-19. There's also mistrust of the healthcare system. There's transportation that's been needed to testing sites. Many of our marginal brown and black communities are essential workers. They've got to continue to provide and work for their family, and they've become very resistant to self-isolation and self-quarantine, and it becomes very difficult when you have a multifamily household with limited space. So we recognized all of these issues. So Dr. White said, okay, we need to provide some way for these counties to have a dashboard of sorts, to be able to go and find the data they need, to be able to leverage that in their communities, to do a better job of placing resources and services in the communities with the greatest unmet need. So Emory has developed a nice dashboard looking at some of those social determinants that I talk about all the time. And one of the things that I really like is called a socioeconomic vulnerability index. And what that does is it encompasses income, insurance, housing situation, education level, and packages all of that into one variable, so to speak. And then it overlays that, you can put that next to COVID-19 deaths in minority populations. So it gives you a good indication of where your most vulnerable populations are and what those COVID deaths look like. And you may not see the two maps being in sync and overlaying, but you also recognize that if COVID-19 were to be in those darkest blue counties, we need to be prepared for that. We need to be ready. We need to know what resources need to be put in those communities based on these maps. So we said, well, if Emory can do it, then Kentucky must be able to do it, and we probably can do it a little better. So we put together a work group looking at some of our rural and urban counties where we're being the hardest hit. So we want to have a dashboard as well as to where we can find that data quickly, where it can be user-friendly, where it's data in real time that can inform communities of what's happening related to their minority populations, and looking at other social determinants, some other social indicators. We want it to be dynamic, interactive, web-based, so we can see the interplay between social determinants and some of the epidemiologic metrics that we're using to track COVID-19 at the county level. So where can we quickly, and also where we can quickly compare each county's cases, deaths, and other social characteristics, comparing them to state and national averages. So we decided as a group to come together and say, where do we want to look first? What is it that we can do already? What is our wish list? What can we realistically do as a short-term win or low-hanging fruit? And what might be something that's long-term, something that we can kind of build upon and have for use later? So we've been doing some work mapping all the GIS mapping of all the cases and the deaths. You may have seen those in some of the governor's conferences, his press conferences. And we said, okay, how can we overlay testing sites on top of our mortality and morbidity maps? And then what does that look like as far as hospitalizations in communities that are hardest hit? What do ICU admissions look like? What deaths are we seeing in ICU related to COVID? And are the deaths occurring at home versus in the hospital? What comorbidities are cases experiencing, and what comorbidities for our folks that have expired were compounded or were exacerbated by COVID? And then look at deaths in our congregate care settings. What do our long-term facilities look like? What do our prisons look like? So here's a map that you may have seen or may not seen, and this is how we are looking at the rate of positive cases in Kentucky. And you can see the visual, right, from the lightest to the darkest. Those with the darkest areas have the most positive cases for COVID-19. In addition, if you want to look at mortality maps, right, our deaths so far as of yesterday, at 5 p.m., we had 518 deaths. So these maps are generated daily and reported out to the governor's office for his press conferences to say something about what we're experiencing in our state. So we have this capability. So we wanted to build upon that, right? We want to make sure that we're protecting our marginalized and vulnerable populations to the best of our ability. So how do we do that? So we strengthen risk communication systems by bringing some of these community leaders together, trusted sources in community, along with our local health departments in these communities, to address some of the misinformation, some of the hoaxes that are going out related to COVID-19, address the barriers and challenges that they're seeing related to care and services, and really denounce the fake news. I can tell you how many times I've seen something that I've read on social media that's inaccurate, that's being shared among hundreds of people. We want to make sure that we occupy social media with the right information, and we want to be intentional and keep the focus on health equity and social determinants so we can advocate for some real change. So what strategies come next after COVID-19? Well, currently we're looking at institutional and structural barriers. What policies or processes are we currently doing that is having a disproportionately impact on certain communities? And then once we've recognized those, we need to bring in community voices to design solutions. And the SSP webinar that I was on prior, we were talking about peer support specialists used in the SSP programs and how important it is to have persons with lived experience to be able to give you feedback and to be able to walk through what that scenario is like for having had that actual lived experience. And then we need to tailor our public health programming and work with the Office of Health Equity to identify best practices and resources when working in communities of color and our other marginalized and vulnerable populations. So why does all this matter? Okay, positive change that we identify through this initial response, through this work group, we can carry that over to improve population outcomes for all people. It provides leadership opportunities to work across sectors, disciplines, government and non-government agencies. It allows us to look at health and social systems that may be built during this pandemic response that we can use as models later. Maybe we can use something that we've experienced and lessons learned from the COVID-19 pandemic that can help us in chronic disease prevention, something to reduce infant mortality rates, maybe promoting positive early childhood development, fostering good mental health, and really impacting other disparate health outcomes. So stay tuned. We're going to be working with this data work group. We're going to be coming up with additional maps and tools that we can use to give you that data, to let you see it in real time, and to be able to actually provide services where they're needed the most. We can look at zip code level. We're hoping to use a tool where we can get down to the census tract level to really look at where the greatest need is and where the most vulnerable populations are. And we can start doing a better job in addressing the needs, not only during this COVID pandemic, but for future. So thank you very much, Dr. White, for the opportunity to share and talk about what the data work group is doing. And I'd love to come back and give a follow-up when we have some real hard recommendations and things to move forward.
Thank you so much, Vivian. Yes, we'll look forward to adding and maybe in our August public health nursing webinar. We pulled people from for this webinar. This will be a short-lived group that will just kind of slice and dice the data. We've asked for folks. We've had representatives from Christian County Health Department, Northern Kentucky Health Department, North Central Health Department. Rania Rice is a member. Dr. Bell from PHPS here at DPH. We have Epi Rom as well as Amanda Wilburn. Because we know the governor is planning on doing a statewide level health equity task force, and he's going to turn around and ask us for all this data, and we want to already have it ready for him and maybe even have some data ready for him that group hasn't even thought about. So you'll see what that list of things that we're going to look at in the Black and Brown communities as we look at that data in more detail, and we'll be excited to share that with you soon. So thank you, Vivian, for helping us understand that. Next, we're going to go to a presentation from Miriam Silman. Miriam is, I want to say, a new staff member to the cabinet, but I believe she's been around now it's been a year. Miriam was brought into the Department for Behavioral Health Development and Intellectual Disabilities, and her specialty background is in trauma-informed care. So she's the trauma-informed care program administrator. She is leading a cabinet-wide group that Behavioral Health BDID has pulled together, and since our new secretary did this kind of work when he was working in Louisville before he came back to the cabinet, He has taken a special interest in this, and he and Miriam are leading a group, because we feel like before we can talk about trauma-informed care to our clients we work with, we also need to look at trauma-informed care in ourselves. So I'm going to turn this over to Miriam. She's been a great inspiration for me, and I hope that in this world of COVID-19, when everyone is working crazy hours, crazy energy, lots of stress, I think Miriam will give us a good window into ourselves and help us as we care for each other as public health workers. So, Miriam, thank you so much for being here with us today.
Sure.
And we are recording this webinar, and we will share the slides. So you will see, this will be on our nursing web page in probably about a week. So you can just sit back and really listen and take in what she has to say today.
So, Dr. White, are you seeing my slide?
Yes, we are.
Great. Okay. So I'm going to move it to slideshow, and is it showing up now? Perfect. Okay. Nice to meet everybody. And I just want to say at the outset, we're going to do a very kind of superficial look, but if this is an area that you're interested in doing more around, I would be happy to come back. And I also just want to say that I am so excited about the data disparity work group. I think that's so important, and cannot wait to see those data, and to learn from that in some way. So I want to spend a few minutes just talking about how COVID-19, and actually I've kind of expanded this to be the triple threat of COVID-19, the opioid epidemic, and racial trauma, because I think we're really feeling the stress, and both the primary and the secondary traumatic stress from all three of those epidemics right now. And then we'll talk about a few coping strategies. So I always like to remind everybody that whenever we delve into this area of trauma, and trauma-informed care really can't happen without secondary traumatic stress awareness. We can't be trauma-informed in terms of the work that we're doing unless we're also paying attention to our own resilience. So I've actually kind of flipped my thinking, in part because of the influence of the secretary, who's so resilience oriented. And we're really now trying to talk about this in terms of workforce resilience. But anytime we delve into this territory, I just want to remind you that this can be a bit of a reminder or a trigger for us in some ways. And it can, sometimes what we find is that when you are in the midst of doing your job, you can tolerate a high level of trauma exposure. And when you stop and you reflect and you kind of take a minute to breathe, it washes over you in a different way. And I always like to remind people of that. Under normal circumstances, you guys are exposed to a fair amount of adversity in the folks that you're working with, and trauma that they've experienced, and in the communities. But with COVID-19, and as I said, the opioid epidemic and racial trauma, we're seeing even more. So just reminding yourselves to find those spaces that are safe for you, where you can process and metabolize what's going on a little bit. So part of what we want to remember is that this triple threat changes how we're feeling, how we're thinking, and actually what we need in order to be able to do our job. And I don't want us to think that we just continue doing things as usual when we have these added stresses. We have to actually be realistic and say, wait, this is going to be an added stress, and we may need some more supports, or we may need to attend to ourselves and one another in a different kind of way. So, how has this stress impacted us? And I think that, we have both the personal stress that COVID-19 and racial trauma and the opioid epidemic present for us, and then we have the stress in the workplace. And so you can see, we're always going to be concerned about, for COVID-19, our exposure and contagion factors. It's one thing to have that and to be able to also have our normal ways of coping at home, but when we're all social distancing, not just healthcare workers, but everybody, and we're all confined at home. That raises the stress level a whole level, more than just a notch. And integrating work and life, as I'm sure you know, the sense of being isolated or disconnected. Some of us are experiencing some pretty significant financial stress, and I think that even just the anticipation that if the economy still stays in a recession or in more of a recession, what will that mean for the future creates stress. And just to remember that the uncertainty that we have both professionally and personally, you know, how long is this going to go on? What does this really mean? Is there enough PPE? When are kids going back to school? Is there childcare that's going to be available, et cetera, is very anxiety provoking. And we know that, you know, uncertainty breeds anxiety. And then you also have tremendous anxiety and stress just from doing your job, which is harder under these conditions for all of the reasons listed on the right. And you know, I want to recognize that having to use PPE actually makes your job physically and psychologically harder, as well as the fact that you are in positions where you may be experiencing grief because you may be losing, in addition to maybe in your personal life where there have been losses. Professionally, you may be aware of the losses from COVID-19, and you certainly are aware of losses around the opioid epidemic. So just to acknowledge that there are many sources of this stress. I do want to remind you that as with any time that we are under stress, certain things can increase our vulnerability and our risk factors. So if we have a history of trauma, in particular a history of trauma that has not really been processed or we don't feel is resolved. So when you look in the literature and you look at healthcare workers and nurses, you can find studies that say history of trauma increases risk of compassion fatigue or secondary traumatic stress. You can find studies that say it doesn't. And what we're coming to understand is it's not whether or not there's been trauma exposure, it's how that has been supported and how you've been able to respond to it and work it through. Recent losses or a history of significant loss, pre-existing behavioral health concerns, not having a strong external support system, obviously feeling isolated, not having strong attachments or connections to others, poor emotional regulation and limited problem-solving skills in general, or other kinds of stressors. So when you think about our current situation, many of these are going to be present for us. So we do have lots of increased risk in a lot of ways. I want to point out that there are a number of ways that the threats to our resilience manifest. So there's always burnout, which anybody in any job can experience. In healthcare, burnout can definitely happen, but we also know that because healthcare, as with behavioral health, has higher rates of secondary trauma exposure and is by its very definition, is a helping profession, that things like compassion fatigue, secondary traumatic stress, and vicarious traumatization and moral injury also happen. And these things definitely overlap. This diagram is probably not accurate in depicting the degree of overlap. I think it's greater than what the diagram shows, but you can understand the idea behind it. And, you know, we're not going to tease out the differences between all of these. They are slightly different, but I just want to remind you that there are a number of ways that our resilience is tested and threatened and challenged. And so to remind you that when you're feeling not as strong, not as resilient, not as able to do your job, it really isn't about your ability at all. I do want to just take a minute to remind you of this concept of compassion fatigue. And this came out of the behavioral health world, but definitely applies to other areas and now, you know, is recognized as applying. And it's related to this idea that when we are in a helping profession, that we can run out of the amount of empathy that we have unless we are replenishing it. And so that it's not enough to be doing a good job to help our patients, but that we have to also be taking care of ourselves to make this sustainable. And so this points to the emotional duress and distress that we can feel, and it generally happens gradually over time. And not only does our empathy start to erode, but that definitely impacts our sense of optimism, our hope, and manifests as feeling like we're not as compassionate, and not only externally towards others, but also internally towards ourselves. After the concept of compassion fatigue was developed in about 25 years ago, around 1995-96 by Figley, within a short period of time, people started talking about the fact that they were noticing in providers, initially behavioral health providers, but then we really recognized this in emergency responders and healthcare workers as well, and then subsequently educators, law enforcement, all kinds of professions that are in a helping role. But what we noticed was that folks were having symptoms of what we thought was compassion fatigue that looked very much like post-traumatic stress disorder. And what they realized is that you could have a traumatic stress response even if you hadn't had a primary trauma exposure, if the way that you had had trauma exposure was what we consider secondary trauma exposure through the traumas of the folks who you're working with. And so just to kind of frame those two things as we talk in general about workforce stress and workforce resilience for you. I want to just remind you, as you know intellectually, but may not always apply to yourselves, that there's lots of ways that stress manifests. So we certainly are, attuned to paying attention to physical responses in others, but to, again, kind of hold a mirror up and think about how are you doing physically? And are any of the things that you are feeling perhaps related to stress and not other things? And sometimes we recognize that, but then the trick is, what do we do about it in some ways? Of course, we also know that stress creates an emotional response, and that can be across a lot of different ways of manifesting that seem to be kind of, go in opposite directions. And that's because stress, like many things, is going to be very unique for each of us, and it'll be different, and it may even be different at different times in our life, or move between some of these responses. So it sometimes is harder to identify in that way. We don't often think about the cognitive responses to stress, and if we do, sometimes we just think about it as, oh, we just feel kind of overwhelmed. But one of the things that we know is that stress really takes a toll on our frontal lobe functioning and our ability to think clearly, to problem solve, all that executive functioning that we do with our cognitive brain, our thinking brain. And it creates a little bit of a vicious cycle where we're not being as efficient and effective in our problem solving and our thinking. We're not as creative and innovative, and then we get more frustrated, and that adds to the stress. So you can see how that can spiral out. I also think it's important to point out that sometimes the impact of stress on our way of thinking is that it causes us to become less optimistic, more cynical, more negative. And again, you can figure out how that can create its own vicious cycle in a way. Obviously, lots of social and interpersonal effects from stress, which you're probably well aware of. Again, thinking about really taking that moment to pause and thinking, I'm really good at identifying this when it's happening in other people. Am I giving myself the time and the space to know that the stress that I'm experiencing may also be affecting me in those ways? And then we'll start to think about what kinds of supports can help in that. And then, of course, our behavioral responses. And once again, I think that, we know that healthcare providers and behavioral health providers, first responders, law enforcement, have sometimes higher rates of using maladaptive or not so healthy coping mechanisms than we would like to believe, because we're really good at just pushing on and doing what we have to do, but sometimes that comes at the expense of our own well-being. And so to really start to pay attention to that for ourselves and for our colleagues and those we care about in some ways. So let's think a little bit about the protective factors and the strategies that can promote resilience. And probably nothing on this list is really new to you. But the trick is, how do we integrate it at times where we are so busy? And also, I would like to just say that if all it took to manage stress, particularly secondary traumatic stress and workforce stress, was to eat more kale and do more yoga, none of us would be as stressed as we are because we would know what to do. It's not that simple. And it's not completely up to us as individuals. There also is a responsibility for our organizations. And so one of the things that I want us to start to think about is, what can you do in your agency that can help you, promote a resilient space, both for yourself and for your colleagues. Okay, so taking care of your body are things that, again, you know. My challenge to you is to think about, is there an area here that you could do a little better in? For me, it's always sleep, but for other people, it may be something different. So to really just take a minute and think, is there a way that you can elevate this as a part of what you know is necessary for you to do? You know, there's lots of things that are necessary in your life that I'm sure you don't skimp on. And we tend to skimp on the things that are necessary for only us. And here's an opportunity maybe to elevate this a little bit more. Taking care of our body is really important, but taking care of our mind, it turns out, is one of the biggest ways that we can combat the psychosocial impact of stress, including stress from work. So a lot of times we think, well, you know, if the stress is from work, then some of these mindfulness activities or relaxation things that we do in our personal life isn't really going to change the work environment. And it may not change the environment, but it may change our ability to navigate it and manage it. And so I can't stress enough that, you know, the research continues to come out around mindfulness. And when you think about what you know about the physiology of stress, and the fact that we know that the stress response is a brain and body response. And we know that if we can train our brain to be able to down-regulate, that can help our body. And we actually have seen that we can down-regulate the levels of stress hormones. It can help manage the stress response that's happening in the amygdala. And literally, they're seeing that people who do practice regular mindfulness and are under a lot of stress, they're not seeing the same changes in the amygdala and the hippocampus that they do in folks who have chronic stress and don't practice mindfulness. So we do see some real physiological benefits, and it's, you know, sometimes hard to wrap our heads around that, but just to put that out there, that it's not just about feeling better, it's literally about being better. And the same thing is that, you know, there is this research that tells us that our attitude can really change our body in so many ways. So things like positivity and hope and gratitude. So how do we work that into our lives? And I think that the thing that we all have to remember is that we don't need to do this for long periods of time. So what the research tells us is that small doses on a regular basis, like any other medicine, is helpful. So, you know, waking up and saying, what are you looking forward to today? And at the end of the day, finding something to be grateful for may be enough to actually make a difference in how your brain metabolizes and responds to external stress, which is kind of fascinating. So finding ways to work in small doses on a regular basis can be very helpful. I would also encourage you to think about how you can do this in your workplace. And one of the things that I try to do is to start every meeting with either a moment of thinking about gratitude or positivity of hope, or sometimes 3 deep breaths for a moment of mindfulness. And just to create a space that gives people a moment of pause and something positive in their day can be very beneficial. Part of taking care of our minds is also granting some compassion towards ourselves. And, you know, there's lots of literature out there about self-compassion. Kristin Neff is the guru of that area. And her research tells us that there are 3 components to self-compassion: self-kindness, common humanity, recognizing our common humanity, recognizing that we are part of that common humanity, no more and no less, and mindful self-awareness. And so part of this is, again, taking that moment to grant ourselves a little bit of extra compassion, the same kind of grace and forgiveness that we so readily extend to one another and to those we take care of and serve and provide services to grant that to ourselves, which is much, much harder than it seems. For Neff, the way that we get to self-kindness is to have some kind of positive self-talk. And, you know, I'm a therapist by training, but I have a really hard time with self-talk, even though I know from the research that it works and I know from my practice that it works, but it's hard to do and it seems kind of goofy sometimes. But figuring out one thing that you can say to yourself on a regular basis that is kind and that it recognizes the incredible work that you are doing, whether it's in your workspace or in your personal life, can make a big difference. When we are regaling ourselves with something that maybe we think we should have done better, or we didn't do, you know, we didn't make the time, space, or energy for something, instead of focusing on what we could have done better, is to think about how we would respond to somebody else who presented with this situation. And probably we would find the strengths, and we would also find a reason why at this time and place doing more wasn't possible. But again, we don't often extend that to ourselves. And this isn't about making excuses. It's also about recognizing that at different times in our lives, we're able to give more or less depending on what is happening, and to be realistic and accepting of that. And then the last piece around mindful self-awareness isn't necessarily a full-blown mindfulness practice, but what this is just recognizing when we are suffering, when we need some extra help, recognizing that we are not superheroes all the time, and that it's okay to sometimes ask for some help in that way. We also know that being on as regular a routine as possible is helpful. Our brains seek patterns. They find safety in having routines. And when we are experiencing additional stress, having a routine can be a huge support and a huge help for us. I know that in this time where everybody is under one roof, that may be really hard, and where you're having to scramble to find childcare or care for other people who depend on you, this may be very, very disruptive to your routine. So I get that, but as much as we can, we know that that is a helpful thing. We also know how important connections are. And, you know, we are very good, again, at helping other people to find ways to stay connected. And I just want to remind you that this is important both for our professional and our personal lives. And one of the things about staying connected professionally is that because you're all working, you know, in a different kind of way, and because of PPE, you may feel less connected even when you're physically in the same space. And to recognize that and think about what do you need to do to maintain some of those connections, and to be able to have that support that those connections provide within your professional realm as well as your personal realm. We know that being pro-social is a tremendous help to combat the negative effects of stress. And I always hesitate to bring this up because the irony is that all day, every day, you're doing something for others. So here's the catch-22. The catch-22 is that the pro-social benefits don't come if the pro-social activity is happening in the context of our work, which is the source of the stress. And so this does add a tiny little bit of burden, but the thinking is that a little bit of investment can reap some tremendous benefits. So the benefit of doing something pro-social is finding something that is different from the pro-social activities you do as part of your job, as part of being nurses and public health providers. And how can you find something that you feel good about, that does something for others, and actually gives you some more immediate gratification maybe, and you can see the results of. So lots of people are, rallying to do this in ways that connect them through their faith communities or other social service organizations, or even just something in their neighborhood, picking up groceries for a neighbor, or acknowledging a special occasion that can only be noted in a virtual way now, all different kinds of things that are very small gestures, but that actually we know biochemically not only benefit somebody else and raise their endorphin level, but actually raise ours as well, as the helper, as the giver, as the person who is doing that pro-social thing. And we know that when our endorphins start to go up, it's a good challenge to the stress response, the biochemical stress response of the cortisol and the allostatic load that we're having in our bodies. I'm going to send, when I send the copy of the slides, this tiny survival guide, and I'll also tell you how to find this online. It is longer than this slide can show. It comes from a place called the Trauma Stewardship Institute. And one of the things I love about it is that it's very, very small, tiny acts that we can do on a regular basis that can help mitigate the negative impact of the stress that we're all experiencing. And this came out prior to the racial trauma shocks that we've had over the last few weeks, almost month now. So this was in response to COVID-19, but I think it benefits regardless of where the stress is coming from. And again, just really small things that can make a big difference. That's where it's available, but I will send it to you also. I want to just spend a few minutes acknowledging that this is a time of loss, grief, and sorrow, and that the normal ways that we address loss, grief, and sorrow are limited by social distancing right now, and also to acknowledge that there are many types of losses, and some of them are big and tangible and real, and some of them are very ambiguous and intangible and seem, relatively speaking, less. I'm the mother of an adolescent, and she, has lost all kinds of developmental opportunities. I'm ready to ask the governor to declare it an emergency, that she has to be able to get her driver's license because I can't stand driving her around anymore. But among other things, that's a real mark of independence that kids need at that particular time in their life. But in the scheme of things, she keeps reminding me, Mom, we're so lucky. We have, weathered this stress and this trauma of COVID-19 relatively well, and the other stressors as well. And so you feel a little bit guilty about feeling that loss and having a sense of grief. And I just want to remind you that we don't choose what feels like loss or our grief responses. They just come, much like love just shows up too sometimes. And so to acknowledge it and to honor it is okay, and to recognize that, yes, you do recognize that it may not be the biggest kind of loss under the circumstances, but to remember that those ambiguous losses sometimes are even more problematic because if we don't stop and acknowledge them, they can persist in their sense of troubling us, and grief in general can wax and wane and persist for a long time. But I would encourage you to be honest and to help your family members be honest about what it is that has felt like a loss during this time. I have a friend who, she hates to cook, and she said she feels so stupid, but what she really misses is being able to go out to a restaurant, and yes, takeout is helpful, but she really misses that, and she feels really guilty that that's what keeps coming up in her brain. And it's real for her. She recognizes it's not the end of the world, but nonetheless, she feels it. So to acknowledge what it is that we may be feeling, and to recognize that anytime that we experience grief in the present, it also may trigger our past griefs and losses in that way. I want to give you two strategies before we wrap up that may be useful for you to think about in your workplace, because I said that this is not just a burden for you to bear independently. The first is what we call low impact debriefing. I like to call it low impact processing. This comes from some colleagues of mine in Canada at the TEND Academy. And it has 4 steps. And the idea behind this is that when we've experienced something that is challenging or a trauma in the workplace, our immediate inclination usually is to go and tell somebody else and unload it a bit, because that makes us feel better. And the problem with that is that by doing that, we then share the trauma and we re-traumatize them, and sometimes actually even re-traumatize ourselves in the sharing, even though it feels like it may be discharging it in some way. So Francoise suggests that we take these 4 steps. The first being aware of what is it that we need. And if we really think about it, what we need is not to share the trauma. What we need is to share how we're feeling, how that trauma exposure is making us feel. Sad, depressed, frustrated, angry, powerless. All of those things are common responses when something beyond our control of a traumatic or strongly adverse nature has happened. So once we recognize that, then we can separate. I don't actually have to tell my colleague what just happened. What I need to tell them is how I'm feeling, that something happened and it's making me feel crappy. But then we also have to recognize that we don't know how our colleagues are doing. Our colleague may have had a difficult day themselves, and it may be that they don't have the capacity to listen to any more. So we need to ask instead of just go in and say, oh my goodness, you won't believe what happened, bleh. So instead of even by not sharing the trauma, by just sharing how we're feeling. So we ask, hey, I really need to talk about something that just happened, how it's making me feel. Do you have a minute? And guess what? The person is allowed to say, not right now, or I'm really sorry, I'm having my own busy day, or whatever. And then we find somebody else. And it doesn't mean that they don't care about us, and it doesn't mean that they're not open to helping. It just means that maybe their cup is full. And then once you get consent, again, you're going to share, but with a limited disclosure. We don't have to share all the details. We only have to share the outcome. We can also use this low impact process when you're thinking about sharing cases. And very often we do have to share information about traumas that patients have been through and experiences that they've had. But I would urge you to think about, do you have to give gory details, or can you just give a general overview of what happened? Whoops, this is in the wrong place. So that was about grief and loss. Sorry. So some strategies for grief and loss. I thought that somehow that slide had been deleted, but here it is. I just want to point out the name it, claim it, tame it, which I indicated. We know it sounds like a dumb kind of way to respond to things, but we know from the literature that when we have something that is troubling us, if we can give it a name, if we can acknowledge it, acknowledge how it's making us feel, then we can often feel that we have more control and we can regulate our response to it. Okay. The other thing that I want to point out is that we talked a little bit about compassion fatigue at the beginning, and I just want to point out that one of the things that the literature tells us is that compassion fatigue is probably inevitable in the work that you do and the kind of work that I do. But what we also know is we can sustain that work if we can balance it with compassion satisfaction. And compassion satisfaction is a fancy way of saying what keeps us going, what makes us feel like this job is worth it, the good outcomes that we have, the positives. And sometimes that's relational, and sometimes that's the actual outcome. We can have some compassion satisfaction even when the medical outcome is less than desirable, because we feel like we did everything that we could and we did it in a way that we feel really good about. And sometimes that gets lost. And so what I want to remind you is that in order to balance the compassion fatigue with compassion satisfaction, we have to work as a group and as an organization to really honor what does go well, what you do well, what, the small successes, and to really share those. So again, I think that's a lovely way to start staff meetings, by sharing things that have gone well, especially when the purpose of the meeting or the team meeting is to hone in on what we need to do to solve a problem. We tend to go right for essentially the pathology and the problem of it. But if we can take a minute and acknowledge something good, that can make a big difference in our ability. So to find those moments of grace and goosebumps, to share them, to celebrate them, and to remember them in some way. Okay, so just in closing, I want to remind you that this is good for you to do. These are good things for you to do for yourselves, but also really important to help monitor and support one another at this time. And it may be within your workplaces, or maybe it's in a multi-agency group like this when you come together, but to be aware, to provide resources, to communicate, to acknowledge what's going on, and to seek creative opportunities and offer a lot of support, and to continue to pay attention and repeat these things, because sometimes we hear it, but it's hard to turn it into action, and to turn it into these protective strategies. So with that, I would like to challenge you to set 2 intentions, one thing you can do for yourself, and one thing that maybe you can introduce in your workplaces that can promote resilience for you. And as the governor reminds us, we are a team here. So feel free to reach out to me. I'm happy to go deeper on some of these things. I know this was a very quick overview. And you know, lots of times we really talk about the strategies and go dig deeper a little bit. I'm thinking that you guys know the physiology pretty well. I spend a fair amount of time sometimes addressing physiology with non-medical providers. But anyway, I'm happy to entertain any responses or questions or anything. Thank you, Dr. White.
Thank you so much, Miriam. That was right on target. I took a whole bunch of notes, and I've heard this presentation before and with different people, but I got a lot out of that today. Number one, stop beating myself up. That's at the top of the list. So thank you so much, and hopefully we can have you back.
I'd love to. And I just want to say to everybody on the call, I don't know exactly what you do, but I know that what you do is essential and vital. And as one Kentuckian among many, I want to say thank you very, very much. We appreciate what you're doing, particularly in COVID-19 and the opioid epidemic, but in all 3 and many other areas. My work is primarily in abuse and neglect and interpersonal violence, and I know you have a big role there too. So thank you for everything you do, and stay well going forward.
Thank you so much, Miriam. I really appreciate it. So as I said, we'll have this recorded, and we also will have the PowerPoint presentations up on the public health nursing webinar. So you are welcome to, it usually takes us about a week to get this video back from GoToMeeting and get it finalized so we can attach it. But this will be something I think you're going to want to share with your colleagues. So I appreciate that. The next person we have on our agenda today is Katrina Thompson. I've known Katrina, I would like started to say forever, but that would make us both sound old. But Katrina is, I know Katrina through her work with the March of Dimes. She's been very involved for years with our maternal child health program, with our Healthy Babies Are Worth the Wait program. She was one of the founding mothers, I believe, that was involved in that work and getting that to be adopted by the March of Dimes. The project that was developed in Kentucky by Kentuckians is now a national program that the March of Dimes encourages. Katrina is part of our Kentucky Perinatal Quality Collaborative work. And we were talking about some different things that maybe the KIPQC could do for birth equity. There's a program in California called the Birth Equity Program. We've talked to some legislators about this, and Katrina did mention in passing that the March of Dimes did have some implicit bias training. I was very intrigued by that. I think in a theme with everything we've talked about today, with the stress of COVID-19, the stress of the opioid crisis, and then the racial trauma that we are all witnessing. Some of us have been witnessing it every day of our lives, and some of us are learning and continue to learn every day. implicit bias training is something that I know some of you have done, but we want to hear what the March of Dimes has to offer and see if there's any interest or pattern that we might could look at to work with implicit bias training, not only with our KIP QC program, but also through our local health department. So I asked Katrina to come and give us a few minutes of what the March of Dimes is doing, and she and I will be in further talks if there appears to be interest by health departments to see how we could push that out to local health departments if there was interest. So Katrina, thank you so much for being here. She covers Kentucky and West Virginia, and so she's a very busy woman, so we were glad she could join us today. Katrina?
Thank you so much, Dr. White. I apologize for my camera. It is not cooperating today, and I'm not sure why. I tried to figure it out, but again, this happened. So thank you so much to everybody who is on the call. This is such a wonderful meeting and such wonderful presentations, and I look forward to getting the recording of it so I can share some of these wonderful ideas and talks with others, with some of my other colleagues. As people probably know, March of Dimes has really been working toward the prevention of preterm birth for some time now. And we really made some great progress in the areas of late-term birth rates. You know, when we began working with Healthy Babies Are Worth the Wait, our rates were well over 15%. So we have come down quite a bit. So that's very good. Our medical director, Dr. Rahul Gupta, really began to talk to the staff at March of Dimes and said, you know, if we are really serious about addressing preterm birth and those impacts on those families, then we must address disparities, because that's the underlying issue across all of the work that all of us do. And particularly now, everything's coming to light. There's a lot of conversations about bias, about race, about you know, health equity. So this is a very good time for us to talk about this. So the March of Dimes really wants to address maternal mortality and morbidity, certainly looking at the opioid epidemic, and definitely looking at health equity and how that impacts all of us and all of our programs and all of our families, not only in Kentucky, but across the U.S. We began to look at what we could do to help healthcare providers. That's one of the roles that March of Dimes loves to serve in and is very good at. So we put together a Breaking Through Bias in Maternity Care. I don't have a lot of slides. I only have one sheet to share today, but I'm happy to provide that to you, Dr. White, and you can share it with others if you'd like. It just gives a little bit of the information about what I'm talking about today. But when we look at health equity for moms and babies, the United States is among one of the most dangerous nations for childbirth. I was really, when we began to hear that a lot, that really surprised me, actually. It seems that we should certainly be further along, that women should not be dying in the United States like they do in other countries, as far advanced as we are, and as far as we've come, you know, with medical outcomes and research and all of these things. So I think that is a very disturbing fact. We really have significant ethnic and racial disparities existing in healthcare. You know, and one of the things that we can certainly look at that contributes to that is implicit bias. I've worked with the Louisville Health Department and the University of Kentucky, and several of those people's on a collective impact project that we're looking at around health equity. And we had some we had some groups of women who came and wanted to talk about their experiences when they gave birth, and those stories were so heartbreaking. About the stereotypes and about how they were treated. And one woman even talked about she was a substance user, but had been clean. And so this time for 5 years, had been clean for 5 years. But when she went to deliver her current child, her chart was still flagged as a substance user, and that she was treated very, very poorly, and still treated like, like she was actively using, even though she had been clean for 5 years. So some of those things we really have to look at, and much less if you are, if you are a substance user, if you're African American or of color of any kind. So with all of those things, it just adds more and more layers of bias that can affect the healthcare workers, and it certainly can affect the people giving birth and their families. If you look at, for example, Serena Williams, very well off apparently, has money, was probably given a little higher status in the hospital just because of her fame, and they almost let her die when she was telling them, I'm telling you, this is what's wrong and this is what's happening. And she said she really felt that nobody wanted to listen to her because she felt that Black women had been kind of set aside as being, overly emotional, kind of dramatic. So they didn't really take what she said too seriously, and that almost ended in a terrible demise. I mean, it was just concerning that someone would not listen to that. So those are the things that March of Dimes looks at and really wants to help other healthcare professionals and themselves. Our staff, we all took this training. The training is unique, authentic, has some very compelling content. We had a group of a group of people who looked at this and did it in several pilot sites, and to make sure that it covered everything that was appropriate. It's packaged beautifully, and the training alone won't solve all of our issues, but it will help and lend to improvements in racial and ethnic disparities. It's been proven to increase patient and provider communications. It's increased patients' experience and their quality of care. It's really lending, and it's time for us to have a culture shift. I think everyone will agree with everything that's happening, that it really is time for a culture shift, and this will help us to do that. It helps us to achieve equity for all moms and babies, no matter what, no matter where you're from. And I think all of us have probably experienced bias in some way. You can even look at things like, being poor, paying for your groceries with the EBT card. All of those things, I've even experienced it in the fact that, people think particularly if you're from, Eastern Kentucky or Appalachian, that you're not as well educated, which we all know is certainly not the truth. So when you look at bias, it is across the board, and I think people really do, and I love the speaker before who talked about burnout and everything, and I think that does affect us. I think we become desensitized and maybe don't have as much empathy or sympathy as we once do, and I certainly don't want to criticize any nurses, because my goodness, they go above and beyond. But when you're in that traumatic environment all the time, she's certainly right. This can certainly color our view of who we're serving. The training has really 4 key components. It really gives a good overview of what implicit bias is, and also you can take that personal assessment that's with it. And people often find things that they think, oh, I didn't really think about that, or oh, I think I do that, or maybe I really do have some bias. The second portion is a historical overview of the structure of racism in the United States. A lot of people don't realize some of the things that have been happening for many, many years. And although we weren't the ones living in that time period, this has still affected our races and generation after generation after generation in those people of color. And understanding that. We have strategies to mitigate racial bias in maternity care, and how we can look at that to keep bias at the absolute minimum, and hopefully to absolutely do away with it as we continue our cultural shift, and building a culture of equity within our organization. I think that's important, not only for our patients, but for our coworkers, for our friends, for our families. The March of Dimes, I know this only lists 2, but we have several different ways that we can do this. We have a live training. When I say live, it's not in person, because it's COVID right now. None of us can do anything in person, nor would we want to. But it is live via Zoom. And a March of Dimes facilitator actually goes through this and works with participants. I think it's up to 100 people. And there are CEUs available with this, and CNEs. With all aspects of this. And then we have a new program that's coming out with this, where it's a webinar where it's available for 3 months with access to it, but I'm not sure how many people would have access to that. They're still working on this. This is absolutely new. It just got released like a week ago. And then you have the e-learning, which is an individual training where you just go in and it's self-directed, and you could do it at any time of day or night, which is good for some of the folks who work different shifts and that sort of thing. But this is something that March of Dimes is really passionate about, and it's very well packaged. It has the resources listed for you. It has basically everything you need in this prepackaged toolkit. And I'm happy to answer any questions.
Wonderful. Thank you, Katrina.
Absolutely, my pleasure.
And I'll go back to the quote that Vivian said, that I always read it, so I don't want to do Maya Angelou a disservice. But she says that do the best you can until you know better. Then when you know better, do better. And so I think that is to me is what implicit bias training is about. We're all doing what we think is the best we can do, but we need to continue that self-evaluation that Miriam was talking about. We need to look at the data that Vivian was talking about and figure out how we can do better. And I think this will be an opportunity for DPH to partner with the local health departments and see if there's a way that we might want to partner with March of Dimes. So if there aren't any chat questions right now, I don't see any in the box. Okay. Then thank you, Katrina. We appreciate it. And I know.
Absolutely. Thank you. Thank you for allowing me to share and be on the meeting today. I appreciate it.
Thank you. Okay, so to wrap up, the last thing I wanted to talk about today, because I'm going to have to hop off here and do another meeting, I am the queen of Zoom. It seems like Deb is nodding her head. I did want to talk to you about what the Department for Public Health and the Kentucky Department of Education have been doing. I know you are getting lots of calls from your local health departments about school reopening, how we're going to reopening, what's going to happen, what involvement does the local health department have in that reopening. So we have for the last month met every Tuesday afternoon with they have a superintendent's call, very similar to our local health department call that we have on Thursday afternoons. They have them with superintendents on Tuesday afternoons. The first one of those meetings we went to, Acting Commissioner Brown was very gracious and turned the meeting over to the Department for Public Health for the first hour. It actually went 2 hours and 15 minutes. Is how long people were asking us questions. So it started out with Dr. Stack doing a presentation and then followed up with me, Dr. Emily Meslerly, Jan, who's the branch manager for immunization, who is a APRN and used to be a school nurse in Lexington. We had Jan Bright on that call. Jan, as you all know, is a branch manager here at Maternal Child Health and has been very active in school nursing in her nursing career. And then we had Becky Gillis and Erica Brakefield from our Department for PHPS, Public Health Protection and Safety, addressing environmental issues. So we answered their questions that hour and 2 hours and 15 minutes. We came back the next week and answered questions for an hour. We came back last week and answered questions for an hour, and I believe this week was our 4th week to do that. We have also been meeting with a team from the Department of Education, and I did miss that call today. It's Thursday mornings at 10 o'clock, so Jan and Emily were on that call. I was not able to join because I wanted to be here with you. But we as at DPH have pulled together a document that we think here at DPH addresses issues of public health. We have sent that to the Lieutenant Governor. As you know, the Lieutenant Governor has been an assistant principal and a basketball coach and a teacher in her life before she became Lieutenant Governor. And she is now the Secretary of the Cabinet for Education and Workforce Development. So she and Commissioner Brown and his team are looking at that document, and we're trying to figure out how do we operationalize that in a local school district, recognizing that what happens in Louisa and what happens in Louisville are going to be 2 very different things. But nothing in that document that I can't release yet because it has not been released by the governor's office. That's kind of how things work here. But that document will not have anything in there that will be of any surprise to anybody in public health. The 4 main things that we talk about are social distancing, wearing masks, temperature checks, and hygiene, the environmental hygiene and the hygiene of the people that are in that school system. So all I can tell you at this point is those meetings are ongoing. I'm very hopeful that very soon we'll have that document to be released and we'll share it with you the minute that we can. You will probably, as a health department, be called by your school. I would hope that would be something they would normally do and say, just as they did with prom and just as they did with graduation, here's what we're planning on doing. Does this fit the public health principles? So we do have, and of course, right sitting here now, I cannot remember the email address, but we'll send that out to you. If I don't write it down, we won't. But Dr. Meslerly and I and Becky Gillis have a email address that we're setting up. So if you have school questions, you send it to that email address and one of us will respond to you that day. Because we don't want you to not know who to call. Do I call environmental? Do I call Dr. White? Do I call Jan? We've got one place where those emails will be responded to be sure that you have timely answers to your questions and that you are getting consistent answers and not a bunch of different answers from different people in the Department for Public Health. So that's what we've been trying to do. We will continue having those meetings to be sure that we have a document that is something that you can be very supportive of, that will allow schools to open, because as we know, the spread of COVID-19 through the state is not something that any of us want to see happen, but we also know it's very important that children are back in a school setting where they find that routine that Mary was talking about and the comfort that they have in the routine and their mental as well as their physical health. So there'll be more on that. I will get that email address sent out to everyone so they'll know what that email address is. I also wanted to talk in responding to what Katrina said, is I'm hopeful maybe by August we will have our PRAMS data ready for report. PRAMS is in relation to what Katrina, when we were talking about implicit bias, PRAMS is the data where we were funded by the CDC to contact women at 6 months and 1 year after delivery. How were you treated? What did anyone ask if you had a substance use disorder? Were you referred for treatment? Are you still in treatment? How many visits did you have? What was your delivery experience like? Those types of data are not available anywhere else unless you have a state that's having a PRAMS report. And so I'm hoping that we'll be able to have that for you very soon. So we can at least get a snapshot of how are our women being treated during pregnancy, and we can pull that in postpartum, and we can pull out looking at the disparities just as we're looking at the disparities in COVID-19. So getting you the email for the schools, getting you the PowerPoints and the recording. We will have that as quickly as we can. Are there any questions in the chat box? I didn't see anything pop up. Okay. I'm very excited that you have stayed with us today. I think we've had some really interesting things, and thank our speakers. Thanks Sharon and her team at EWD, but as most importantly to thank Deb. She is my heart here at DPH, and I could not function through the day without her. So in a moment of gratitude, I want to tell everybody in the state of Kentucky that Deb Colston rocks. So if we have no other chat questions, we will see you in August the 20th. Now, the problem with August the 20th is that's going to be the same day as our harm reduction summit that we are going to be doing virtually. So we'll figure out a way to work that out. There may be a chance we may even move that a week, but if that happens, we'll send you that notification out within the next week. I will make that change right away so you can change your schedule if we need to do that, because we do want people August the 19th and 20th to participate in our virtual harm reduction meeting, where we'll have keynote speakers, we'll have breakout sessions, and it will meet from 10 to 2, so it'll be the middle of your day. You can bring your lunch. We'll have speakers, we'll have breakout sessions, and I think you will be able to learn a lot from this, so we don't want to interrupt with that. So we will see you then in August at some time, maybe the 20th, maybe a different date, but we will let you know right away. Thank you for all your hard work, being there on the ground, caring for all of our patients in Kentucky. We are most grateful. Thank you for your service. Bye, everybody.